Hello everyone, and welcome to today's presentation. I'm excited to have you here as we explore the topic of anemia through a series of engaging multiple-choice questions. On this first slide, you'll see the title Multiple-Choice Questions, along with the focus on anemia. Over the next few slides, we'll cover key aspects of anemia, including its causes, symptoms, and treatments. So let's get started and dive into this important subject together. So let's talk about which medication class can interfere with iron absorption. Now, this is an important point because many patients are on multiple medications, and understanding potential interactions can really impact nutrient uptake. The options here include beta blockers, proton pump inhibitors, statins, and ACE inhibitors. Among these, proton pump inhibitors, or PPIs, are well known for their effect on stomach acidity. Since iron absorption, especially non-heme iron from plant sources, depends heavily on an acidic environment, PPIs can reduce how well iron is absorbed in the gut. This can be particularly relevant for patients who are already at risk for iron deficiency. The other medication classes listed, beta blockers, statins, and ACE inhibitors, don't have a direct impact on iron absorption. So, the key takeaway is that proton pump inhibitors are the main class that can interfere with iron uptake, and it's something to keep in mind when managing patients who are on long-term acid-suppressing therapy and might also need iron supplementation. This connection ties into the broader theme of understanding drug-nutrient interactions to optimize patient care. So, when it comes to treating acid-related conditions, the correct answer here is B, proton pump inhibitors, or PPIs. These medications are actually the most effective for reducing stomach acid production. They work by blocking the proton pumps in the stomach lining, which are responsible for secreting acid. Because of this targeted action, PPIs provide a more potent and longer-lasting acid suppression compared to other options. This makes them a cornerstone in managing conditions like gastroesophageal reflux disease, peptic ulcers, and Zollinger-Ellison syndrome. Understanding how PPIs work helps us appreciate why they are often the first-line treatment in these cases, aligning perfectly with our overall goal of effective acid management. Let's take a closer look at this question. It asks, which condition is characterized by the bone marrow stopping production of red blood cells? This is a critical point because understanding the different types of anemia helps us identify the underlying causes. Now, looking at the options, the first one is iron deficiency anemia, which occurs when the body doesn't have enough iron to produce healthy red blood cells. The second option, aplastic anemia, is the one we're focusing on here. It's a condition where the bone marrow fails to produce not just red blood cells, but all blood cell types, white cells, red cells, and platelets. This happens because the marrow essentially stops functioning properly, which fits exactly with the question. The third option, sickle cell anemia, is a genetic disorder where red blood cells are misshapen, but production isn't usually halted. Instead, the cells are abnormal. Lastly, thalassemia is another genetic condition affecting hemoglobin production, but it doesn't involve the bone marrow stopping its production completely. So, the key concept here is that aplastic anemia is the condition where the bone marrow completely stops producing red blood cells, leading to severe anemia and other blood-related issues. Recognizing this helps us appreciate how different conditions impact the blood and overall health. The correct answer here is B, aplastic anemia. This condition is characterized by the failure of the bone marrow to produce enough blood cells, which leads to a significant decrease in red cells, white cells, and platelets. It's a serious disorder that can cause symptoms like fatigue, increased risk of infections, and bleeding tendencies. Recognizing aplastic anemia is crucial because it often requires prompt treatment, such as immunosuppressive therapy or bone marrow transplantation. Throughout this presentation, we've been discussing various hematologic disorders, and understanding aplastic anemia helps us grasp the importance of bone marrow health in maintaining overall blood cell balance. All right, let's look at this question about anemia and MCV values. So, when we see a patient with a mean corpuscular volume, or MCV, less than 80 femtoliters, what kind of anemia are we typically dealing with? Now, remember, MCV helps us classify anemia into different types based on the size of the red blood cells. A value less than 80 suggests the cells are smaller than normal, which points us toward microcytic anemia. This is important because microcytic anemia is often caused by conditions like iron deficiency or certain thalassemias. Now, looking at the options, macrocytic anemia involves larger cells, so that's not it here. Normocytic means normal-sized cells, which again doesn't fit if the MCV is below 80. Hemolytic anemia relates more to the destruction of red blood cells and can be normocytic or even macrocytic, but the defining feature here is the small size, which is microcytic. So the key takeaway is that a low MCV, specifically less than 80, indicates microcytic anemia. Recognizing these values helps us narrow down the causes and guides us toward the right diagnosis and treatment. So let's look at this question. A patient with a mean corpuscular volume, or MCV, less than 80 femtoliters. What type of anemia are we dealing with? Now, remember, MCV helps us categorize anemia based on the size of the red blood cells. When the MCV is below 80, that indicates the red blood cells are smaller than normal, which is what we call microcytic anemia. This is typically associated with conditions like iron deficiency anemia or thalassemia, where there's a problem with hemoglobin synthesis or production of red blood cells. It's important because identifying the size helps us narrow down the causes quickly. So of the options here, macrocytic refers to larger cells, normocytic to normal-sized cells, microcytic to smaller cells, and hemolytic pertains to the destruction of red blood cells rather than their size. Given that, the correct answer here is C, microcytic anemia. Understanding these distinctions is crucial because it guides our diagnostic approach and management plan. Recognizing a microcytic anemia points us toward investigating iron levels, hemoglobin synthesis issues, and related conditions, which are central themes in understanding anemia as a whole. So the correct answer here is C, microcytic. When we're looking at the type of anemia, one of the key features is the size of the red blood cells. Microcytic anemia is characterized by smaller than normal red blood cells. This typically points towards issues like iron deficiency or conditions such as thalassemia. Recognizing the cell size helps us narrow down the possible causes of anemia. So, when you see microcytic, think of iron deficiency or related disorders. This ties back to our overall discussion about different types of anemia and their diagnostic clues. Thanks to understanding these key features, we can better approach diagnosis and treatment.